He graduated from the University of Medicine and Dentistry in New Jersey in 1983. But prior to dental school, he received his master's degree in human anatomy at Farley Dickinson University. He's an author, researcher, speaker, currently on the board, and received mastership in the academy, and my good friend, Phil Mollica.
Hey, thank you, ladies and gentlemen. All right, we're still awake out there? Hey. Okay, well, first thing, welcome to Savannah. Can you still see me? You can't miss me, can you? Don't get wise. Anyhow, so I am chairman of the Periodontal Committee at IAOMT, and who are new members here? Awesome. Okay, great. Who considers himself a biologic dentist? Oh, really? Come on, raise that hand. Come on, biology is the way to go. So what we're going to talk about today is the official position of the, as soon as I get my button straight here, the official position of the IAOMT in relationship to periodontal care, biocompatibility care. So that's going to be kind of fun looking at that, okay? And as a periodontal and associated soft tissue committee, because we consider ourselves beyond the periodontium, all the soft tissue of the head and neck area, you know, our mission really, as a group, as a committee, really to look at the newest ideas and advances in periodontal care and soft tissue care of the oral cavity and associated structure with that, because we want to provide safe and effective therapies for our patients. And we're going to talk about that today. So, you know, our goals today, you know, present the official position of the International Academy of Oral Medicine Toxicology in relationship to the diagnosis and treatment of periodontal disease. Well, that's kind of fun, okay? And discuss thinking in an integrated biologic manner. So what I'm going to do in the beginning is go through the basics of the position of the Academy, but then, to finish off the day, we're going to go down into the rabbit hole of biology and take a different look at periodontal care and managing soft tissue, because we want to think differently, okay? If we're thinking in terms of toxicology and things like that, we want to present to our patients safe and effective care. Of course, we're constantly battling what today? You know, years ago it was all these sanitation issues. That's where homeopathy came from. Today is what? We're battling environmental issues in the dental office and, of course, outside in the normal lifestyles of individuals out there. So I always like to think out of the box, okay? And that's always been fun. At least I survived this long thinking out of the box. And, of course, thinking in an integrative biologic manner. I mean, the concept of integration, you hear about integrated medicine, but we really love the concept of integrated biologic dentistry, because it really takes all dentistry and medicine, puts it on a beautiful platform. It's really about patient-centered care, specifically what the patient needs so they can function and stay healthy and stay within the world of wellness itself. So, of course, you know, we want to, see the forest from the trees, that is for sure. And the beautiful trees, and, you know, we do love those trees. And you can see the implication of that as we talk along, because we're going to bring that as a kind of a metaphor with us on our journey today. So, biocompatible periodontal disease control, the official recommendations of the IAOMT, once again. So let's go back in history a little bit, which is kind of interesting how we approached periodontal disease, or the term, remember, I don't know if you know, the younger dentist, pyorrhea. Remember pyorrhea? Oh my God, it's over for me now. You've got pyorrhea. Kind of like that term. Let's hear it again. Pyorrhea. Okay. Gets me, you fool. Anyhow, back on, in 1890s, Willoughby Miller there, he worked with Koch and Berlin. And of course, these guys were of the kind of Pasteur concepts, where the bugs are everything. Okay, the bugs are everything. But is it, or is it the terrain? So they believe both, decay and periodontal disease are caused by bacteria, period. End of story. Well, okay. Well, maybe that's part of it, okay? Going back to the 1920s, of course, they abandoned the theory of bacteria because they really couldn't see the difference if they cultured it or, put it under the microscope, what the difference was. Is there a difference between pathology, a difference between wellness? Well, that was very difficult for them to discern. So, of course, pyorrhea came from what we do. What dentists do. All our perfect margins, all those crowns, all that beautiful mercury fillings. What could be possibly wrong with that? Okay? Well, nothing, of course. Okay? So the cause of pyorrhea was really the irritant from our work to the gingiva itself. Okay, that's a nice piece of the puzzle. 1960, okay? Once again, microbiology tests come around. Wow, bacteria causing inflammation, not the tartar. Well, okay, we can accept that, okay? Once again, they're not really seeing bacteriologically or microbiologically a difference when they look microscopically, but we're seeing, overgrowth of what they call normal plaque of bacteria and causing an inflammatory response. Okay, that's another thought. They call the non-specific plaque theory, okay? So this is when we started the concept of scraping, cleaning, curettage, to cure everything itself. Back in 79, Loesch they decided, well, there are very specific bacteria that cause the pathology, not knowing the really broad spectrum of what we're really dealing with. So we have very specific, type of pathogenic forms, and where the hell do they come from? All of a sudden, certain bacteria are pathogenic. That's interesting, 1979. Okay, this is where we continue the concept of mechanical debridement. Everything's in the gum cuff, everything we do. When you think about periodontal care, where's everything treated? Inside the gum cuff. That's interesting. So the specific bacteria cause gum disease. And back in 86, last century, of course, it's the immune response. It's the immune response to the bacterial forms. That's kind of interesting. So it's not so much maybe the microbes, but how our body responds to it, where we're seeing the problem itself. So if you think about it, all these different things, maybe it's a little piece of everything. What I've listed before, a little piece of everything, not one specific thing that contributes to the loss of the structure of the bone supporting tissue around the dentition itself. So, we looked historically, okay, so we got some pieces there, maybe all contributing to some degree. But the prevalence of it, how widespread is periodontal disease, okay? How widespread is that? Well, we start out early. We start screwing our kids up nice and early, of course. It's always the mother's fault. My dear wife's in the back. Never dad, of course. But, parent the child. And what's very significant from the day these children are born is how that delivery even goes, sets the stage for how your immune system functions. A vaginal birth is vastly different microbiologically than a cesarean section. Vastly different. So what's happening today, they've realized developing your microflora, okay, your microbiome, which we'll touch on a little bit. What they're doing in hospitals now, they're taking vaginal swipes in cesarean section kids and actually wiping the insides of those little children's mouth. Because as the bacteria, your microbiome matures, so goes with it your immune system. One thing I will tell you today, and we'll repeat it again, we are but a small part of ourselves. We are 10% mammal cells. We've concentrated so much on our mammal cells, which is 10% of us. 90% of us is what? Bacteria, a microflora. Okay? Microflora, which is made up of a multiplicity of different things. So for years, when you think about it, when we've been going after, and this is the problem that we're having today, we try to destroy 90% of us for years. 90% of us for years. And with antibiotic therapeutics, and it's an accumulated process. Humanity has ancient bacteria that lives in our gut and in our bodies. We've been slowly killing those off. And we're seeing the results of that today on multiple levels. And as dentists, listen, back to, antibiotics, woohoo, the greatest stuff on earth. In dental school, you learn, hey, anything goes, antibiotics. Root canals, what's the first thing you do? Give them antibiotics. Well, what's the major problem with root canals? Are fungal infection. So you're disrupting the microflora and allowing for opportunistic pathogens to come in. So, Bennett testing we'll talk about a little bit, but that's a way of kind of getting a sense. It's an assessment tool to give a sense of more pathogenic types of bacteria. And, there's an old saying a friend of mine told me years ago, you get periodontal disease from wives, lovers, and dogs. I said, dogs? And so finally I found out what the hell he was talking about, which I'll tell you in a minute. So kids, of course, are infected from their parents. Listen, if you have dogs, cats, other human beings live with you, guess what? You share a lot of the same stuff. Okay, all the microflora, you're sharing it. It's a beautiful thing. So the oral cavity, of course, we know is sterile at birth, and of course, periodontal disease is communicative, okay, passed along. We can pass along very easily the infection, but how the host responds is a separate issue. And of course, the major transmitter is spit. Okay, you spit at somebody, like patients spit at it all the time. Guess what? You're contaminated. So, of course, bacteria is exchanged during intimate kissing. This was a study done in France, of course, and they stood there and actually counted each of those 80 million microbes. And the zombies here do kiss also. Now, I hope you didn't realize that, watching the walking zombies, whatever the hell it is. But they do, have affection also. All right? And so some of these bacteria that we share, some of them are transient, they come and go, they don't take threshold, and some do become part of our microflora itself, okay? So we're sharing. We love to share, don't we? We love to share. That's a beautiful thing. So, dogs. This is where the story of the dog came from. There was a mysterious periodontal disease in 2 kids in Sweden. Okay? They checked their families. These kids were getting progressive diseases. The source of the infection, couldn't figure out where the hell it came from. And the other family were tested. Nothing. Why were these kids having problems? And they took plaque samples for a year on these kids. But only the family dogs had that bacterial form. All right, so only the identical strain came from the dogs itself. And from the dogs came from the same litter. So the kids were, sucking face of the dog. I don't know. Listen, the point, the moral of that story is that you certainly don't want to suck face with this. Okay? That's Henry, by the way. Or, certainly not that. That's Darla. Believe me. That carries everything unknown to man right there. Okay? So, the concept of periodontal disease, how do we, measure this thing? Well, they did a big study, about a national study, and they were measuring pocket depths. Okay, pocket depths. Basically, is there a loss of attachment? Is there, loss of bone, etc.? Between 2 to 5 millimeter pockets. And, they somehow came up with this group of individuals, 65 million people had periodontal disease, okay, based on a stick going down into the gum itself. But, and of course, the problem with periodontal disease, as we know that, a lot of people have these symptoms, but on our end they have the symptoms and signs. But to them, when do they usually come in? When it's progressed. The problem is, it's silent, right? It can go on for years. And all of a sudden, you all have these patients, all of a sudden, doc, I think I've got a problem. They open up the teeth, they're going, didn't it hurt? It was sore once in a while, but I really never felt anything. Like, okay, that's part of the battle, we're having with that. So is more education has value, better belief in the oral health care, all the things we've been trying to do, educate the patients, but, ultimately they have to buy into it and spend time with your local dentist, okay? So patient education has a great value. That's really, really important as far as maintenance. So I had this discussion. I was teaching a course in Austin. I said, we have these wonderful tools today. Okay, we'll discuss some of them to manage the soft tissue. How long do we see a patient for? Half hour, an hour, every 3 months, 6 months? What the hell happens between those times is the level of success. We do all kinds of, they're fantastic. Oh, look at this. And then, we've had patients that come back, and this is when I turn them over to my dear wife, and she just beats the crap out of them, okay? It's when they don't do what? Their homework and maintain what's going on in their oral cavity, all right? She does that mom thing to them, and even the adult guys, okay, I swear I'll do it. I promise. But we're all infected. What's the difference? We talk about infection. That's kind of an interesting concept. Because we are colonized. We're commensal bacteria. Once again, we're 90% microbial. So we're well colonized. What's the difference between the normal flora and infection? What the hell becomes infection It's been that ecology gets out of balance for some reason, that you have opportunistic bugs that take advantage of it. Remember, they're all competing. They're all smart. 90% of us is very intelligent. It has a consciousness. It talks to us. It shares information. It makes things we need. We should nurture it, okay? But when we talk about infection, there's an imbalance, ecological imbalance, that allows these pathogenic forms to rise up and create all kinds of havoc for us. It's a lot of times their poop and pee that poisons us. They're byproducts, they're exotoxins, and of course they're endotoxins that are released into us. So etiologic factors in a kind of a traditional model, you got your pathogenic microflora, your opportunistic microflora. You got our susceptible host itself. And maybe there's a 75% disease prevalence there, maybe. And it's caused by genetic mutations. And that's interesting. How many human genes are there? Mammalian cells, 22,000. Okay, they switch on and off. They switch on and off, do different things. Our bacteria, our microflora, since it's 90% of it, has millions of genetic potential. Millions of genetic potential that they share. They switch on and off, on and off, on and off. And they can become pleomorphic and change depending on their environment. It's an interesting situation. And of course, they're an obliging host, okay? More susceptible. And it's how our immune response comes about. How do we react to this particular upregulation of these pathogenic forms? Is it an intelligent way, where these pathogenic forms are recognized? The immune system speaks to itself, shares the information to identify these specific type of pathogens, and deals with it? Or is it hysteria? We overreact. We start doing stupid things, a stupid immunologic response. So, with an bad response, this is what does our damage. Not so much the bugs themselves, but it's our response to the bugs that does all the damage. Our immunologic response is it stupid or controlled and regulated correctly? And of course, once again, it deals with the connective tissue and bone loss that we typically see, what we call periodontal disease. So health versus periodontal disease, this is some of the kind of simple parameters that we see coming out of where? The sulcus itself, the pocket itself. So once again, everything we're thinking about is in the pocket, okay? So they tend to be gram-positive, aerobic, love oxygen, few white blood cells. That means we're not responding immunologically to our colonization there. No spirochetes. Ooh, we love spirochetes. They're spooky as hell. And then non-modal. It's just a quiescent, happy biofilm that we're living in. The difference is, with disease, there's a lot of psychosis going on. It's getting crazy. It's gram-negative. We don't need oxygen. We don't need any of that. We're tough as nails, okay? But then we have an immunologic response, okay? The white blood cells are coming in, those neutrophils, those polymorphs. We're going to clean this up. And there's lots of spirochetes in there. Lots of spirochetes. And it's highly motile. As these things change, where the hell are they coming from? Do we have everything? Maybe we do have everything, and it's just, once again, environmentally, ecologically, as things change, they rise up on us. So in the non-pathogenic biofilm, the typical species, predominantly gram-positive aerobes. This will be on your quiz this afternoon, okay? Just say these things 10 times, you'll get a seizure of some form. Okay. But the difference is there's no inflammatory response, okay? This is our colonization group here. They're happy. They're supporting us. They love the epithelial cells that they're living with, okay? They're just hanging out, doing their thing, supporting our health and our wellness. And then the environment changes. So when we become pathogenic, we see a lot of gram-negative anaerobes themselves, and we see those spirochetes, what they call the Socransky red group, which is the nasty groups you see on those DNA testing, okay? And of course, you get the gram-negatives and gram-positive anaerobes and facultative gram-positives, and then, of course, fungus itself. Fungus amongst us, those are the problematic, those are the tough ones. When you think about it, if you cleaned up their oral cavity, as we get into this further, if you give them an antibiotic, put the bacteria. You give them an antifungal, okay, for the fungus. You give them an antiparasitic for the parasites. Well, you cured them, but you killed them at the same time, okay? So how do you deal with that? And it's a lot of inflammation going on. The party is out of control. But these bugs just don't hang out. They're just not hanging around. They live in a biofilm, okay? This is, we used to call it plaque. Plaque, okay? Bacterial biofilm. This is where they live. This is their defense shield. It's not last night's meal. It's really not grits from this morning. It's, the concept of plaque is so passé, I'm told. According to our academy, it's passé. All right? It's biofilm. And that is true. All the bugs live in biofilm. We have biofilm everywhere. When you talk about biofilm, and you talk about nurturing the GI tract, which has spent a lot of time in our school teaching about the gut. Because where does the gut begin? Right here. And we certainly know where it ends. Sometimes more than others, that's it. But anyhow, so a reflection of your gut also is a reflection of your oral cavity, okay? That's why there's so many opportunities there. Do yourself some favor. Spend some time learning about tongue diagnosis, the old ancient Chinese trick. I mean, what a story. When we're talking, dental school, you take the tongue, okay? There's no horns growing out of it. It seems to attach. There's no big holes. Okay, it looks good. But there's an actual story there, if you know how to read it. And as dentists, you're sitting there, there's a whole story there. Spend some time looking at that just to get a sense of what that's all about. And it is truly factual. It's a wonderful tool. We just don't see it because we don't know about it. Okay? So biofilm is kind of the correct term that we like to talk about today. We're going to clean up that biofilm. We certainly are. But they're kind of cool, this biofilm. Let's see if this works. Oh, it's working. So the bacteria, they're in those sulcus there in the pocket itself, and they love each other for a little while at least. They send out these little filaments, and they twitch and move and pull themselves together, and they're happy. Because think about it. In the periodontal pocket, it's dark, it's wet, lots of food. Hey, who would want to live there? It's a great place to be, right? So we get past there, you go. But here is when they're pulled from the extracellular matrix, which we'll talk about a little later on. It pulls all these sugar proteins out. It makes this beautiful defense shield that glues them all together because they can swim through them, have a blast, okay? And it is their protection because you must get through, you get rid of the pathogenic forms per se, in the general term. You have to get through what? The biofilm to get to the bugs themselves. Okay? So you have to have an agent that gets through the biofilm. And it's an ecological thing. Remember, when you're talking about infection, you're talking about a very acidic, positively charged environment. The pH drops in there. But as the pH drops in these localized infection area, we'll call it, so does the oxygen concentration. And it's an ecological change. This is ecology, okay? Ecological change. And as the ecology changes, so do the bug forms themselves. So, with biofilm itself, there's few pathogens, no point in producing toxins when there's plenty of room, plenty of food. But what happens is that when they've had enough, their neighbors are getting too close. They're always competitive, these bugs. Okay, they're smart, they're competitive. They want to make sure they have enough food and space. All of a sudden they start to change. They start to change and they start producing toxins, okay? And this is called quorum sensing. There's a consciousness there. This is just not psychos on the microscopic level. They all talk the same language, cytokinase, okay? They all speak the same cytokines. They do. They communicate. They find a nice place to live. Oh, come on in, boys. But not too many because we need so much food. So as things change, they send these molecular signals out called cytokines, okay? And it gets to the point where they actually switch on genes and start producing toxins to start killing off their fellow bugs, but also, which is interesting, is they hijack our immune system. They hijack the immune system to do the dirty work. Okay? So now this mature biofilm has hijacked our neutrophils, our polymorphs, poisoned them. These polymorphs start acting in an irrational way. They go through apoptosis early, and when they dump out those toxic enzymes neutrophils have, okay, and they start to erode the epithelial lining. Once the epithelial cells start to erode and break apart, this allows for infiltration into the deeper tissue. So you have these berserk neutrophils, and it's interesting. People know how neutrophils work. Our immune system is based on the production of ozone. Neutrophils, they found, and antibodies and the immune system in general produces ozone. Now, we thought for years as a neutrophil would come along, gobble up a piece of bacteria, lysosomes would come out, digestive enzyme, dissolve the membrane, and poop it out. It doesn't work that way. What they found, which was interesting, that neutrophils, these macrophages, pack vitamin C inside the cells. They're saying, why the hell was a neutrophil pack a quiescent form of vitamin C within the cell? Well, then they found out through Scripps Institute that they're producing through this water catalytic pathway that those cells produce ozone. Once they capture the bug, bring it in to pinocytosis, they capture the bug, the neutrophil starts to produce ozone. What the ozone does is challenges the pathogenic form membrane, because those have little to no antioxidants. Once it punches a hole through the membrane of the bug, it kills it, and it's the lysosomes that dissolve up the bug. So our immune system, the functionality from the antibodies all the way through white blood cells, produce ozone to kill the bugs. And they always thought it was interesting. The first studies came out about antibodies because they thought they were just markers, okay, produced by plasma cells. They go mark the bugs, send out interleukins out there, cytokines, to educate everybody what to attack. But they found that even antibodies start producing ozone at the infective site. Very, very interesting. But these, once again, epithelial cells, we're going to go back over this, are our protection. Epithelial cells, and I'll repeat this again down the road, love the cuddle. They connect to each other very tight. They use what's called desmosomes, little portals. They hold together, but it's a barrier. It's a barrier. These things poison the epithelial cells, open up the connections between the cells, and allow for infiltration of those parasites, whether it's amoebas, spirochetes, etc. So dental biofilm, once again, is what we tend to clean up and want to clean up. And once again, a bacteria in a biofilm is 1,000 times roughly more resistant to antibiotic therapy than not. So we'll have a short review here, if this works. Yes, it's always nice when things work. You will now see the twilight zone of bacteria forming. This is how biofilm forms in your mouth. This is all bacteria. This is work done at the University of Montana, Bozeman, showing how biofilm forms. I think if I watched this in college, I would have been brain dead. Oh man, that looks good. Now you start to see the spirochetes come in. And it's a concept. Remember you hear about pleomorphism? You know, and that's kind of interesting because you wonder where the hell all these things come from out of nowhere, per se. I think as the environment ecology changes, the concept here is that these forms can pleomorph or change depending on the environment that they're exposed to. You can see the spirochetes coming in and the gel mass of a biofilm itself. This is good for a romantic evening. Kiss me, you fool. Oh, gosh. Bring the dog in, please. About 16 hours or so. And that should come to an end. But you see, these, once again, do not underestimate your microbiome, your microflora. They're smart. They have a different level of consciousness than us, but it's an intimate relationship. We could not live or survive without our microflora. Okay? Believe me, they produce a tremendous amount of things, which unfortunately we don't have time for. So the beauty of this, biofilms move, they go through clavicular flow. They move around. You can see here, if it works. There we go. Let me see if I can get these going. But anyhow, it flows, just shear forces. A healthy biofilm flows in and around the clavicular fluid. It's just a natural flow, a natural dynamic in the tissue itself. So when you think about it, and this is, where the problem is with antibiotic therapy. Okay? The problem is that you give antibiotics to someone. It's an accumulative thing. You can kill off 1 million bugs. But if there's 1 or 2 left that happen genetically to be resistant to that bug, it doesn't take long for them to dominate. Okay? So you see where E. coli, just 1 dividing in 15 minutes, can overtake. And this is where we're seeing the antibiotic resistance. The era of the antibiotic is over. Okay, the last thresholds have been crossed, and there is not one pharmaceutical house in the world doing any antibiotic research right now. Not enough money. So what are the alternatives? That's interesting. So with biofilm, we know as it matures, it becomes much more destructive. We know that this biofilm that's housed all these bacteria where they live, okay, if you wreck somebody's house, they can't live in it. So as this biofilm becomes more mature, the bugs in it become more mature, more virulent, okay, and more problematic, okay? So if we destroy or disrupt the biofilm, okay, keep it at an immature state, we have a chance to maintain an immature, progressive, healthy, commensal population of bacteria in the oral cavity. If we let it sit and fester, then it becomes more pathogenic. So once again, the biofilm can reorganize from scratch, but if we keep it at an immature state, which is the oral hygiene things we do, the irrigation, all those kind of little tricks we do, we can have a healthy oral cavity to some degree. So consistent disruption of the biofilm is what we do. That's what's called home care. Keep it clean. Scrub, get proxy brushes, all kinds of stuff in which you talk about it. So the significance of the point where the biofilm and the bacteria in there become so virulent, so mature, that they hijack our immune system, this is where when we get to the periodontal disease, okay, this is where we're getting the tissue invasion. The epithelial lining is being broken down by us as an autoimmune disease. So is periodontal disease really an autoimmune consequence? Okay? It becomes a reservoir because they live inside the epithelial supporting tissue. So we clean it up and then they reinvade again. We go back to periodontal disease, then ultimately it leaks into systemic disease. Okay? So the systemic association of periodontal disease, gravity sucks. That's the way it is. All these toxins, all these poisons in your face and jaw, guess what? They drain down through your lymphatic system, down to your chest, whatever. So this is where the systemic problem comes from. But the systemic problem for periodontal disease, if you look at all the things that we've known associated with periodontal disease, they're all chronic inflammatory conditions. Our immune system just overreacting and damaging ourselves. These are all chronic, really non-communicative type of diseases. We don't share these type of diseases. They're unique to the individual, but they're really based on an inflammatory, infective process that's shared from the oral cavity and probably many other little spots also. So once again, we can talk about the concept of, is periodontal disease autoimmunity? And can we reverse that concept? Okay, so just a little quick review. Biofilm is biofilm. It's not plaque. All biofilms are not pathogenic. They're part of us, okay? When they're left to fester and the pathogenic forms take threshold, they're all opportunistic, that's when they become pathogenic itself. Pathogenic periodontal disease is not a microbial infection, okay, per se, but it's the inflammation, the damage, and how we respond to the interpretation of that microflora that does the damage to us. And of course, periodontal inflammation increases the risk of systemic medical inflammation, and the microbiology of health and disease are different now that we can recognize them. And how do we recognize that? So, everything we've been talking about is inside that pocket, okay, our little sulcus, all right, that microcosm in there. And we've looked at it, well, the autoimmune component, okay, maybe destroying the bone, the supporting structures. Okay, we can understand that. But you've seen cases where they're weird. I mean, they come in, everything looks great. There's no pocketing, there's no bleeding, the tissue looks wonderful. But you notice over time, there's a progression of bone loss. What the hell's going on? So, well, is the occlusion? You check it. Oh, this is beautiful. Everything's going on. We have a bigger problem that we were just talking about, is fluorinated pharmaceuticals today. You know, I didn't realize, a friend of mine, one of our students did a presentation on this, and I was like, holy smokes. You know, all these areas, anesthetics, fungals, I mean, you know, appetite suppressant, antacids, you heard it just before I came in, the whole deal with Dave Kennedy. All these pharmaceuticals that were pounding everywhere have fluoride attached to them. The fluoride, you know, destroys what? Poisons bone. So we're like, wow, everything's healthy, looking good, and the bone going dun 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 dun. That's just not in the jaws, but all the whole body. So what happens is, here's Celebrex. Oh, we love Celebrex. Oh, we feel good on Celebrex, don't we? Okay? The problem is, look at the fluoride attached. So what happens when a pharmaceutical comes, you plop it in. Okay, take it in, that's good. Okay, 20 minutes, I know I'm going to feel better. Well, it went through your gut, it's gone through your liver, getting stripped, getting more water soluble so you can activate it, all that. What's happening is you're stripping the damn fluorides off. Where do they go? Into the bone. All over the place. So as you see, we're being, poisoned in all different ways. So once again, it boils down to, when you see these patients or your patients, okay, you got to talk to them beyond what they're, normally doing. Are they brushing, cleaning, etc.? What's pharmaceutical agents are what they're doing? And also how much time they're spending on that damn phone cooking their heads. Okay? So think about that. The Celebrex and the multitude going back. This is almost every pharmaceutical agent there is. They're pinning those fluoride molecules go on, and they get stripped off, and they're free fluoride running around and being incorporated into the bone, slowly poisoning your hard tissue per se, but also your brain. Your brain on fluoride. Much use a big drug. What's your brain on drugs? They put frying eggs in a frying pan. Remember that? Well, some of you would. Now it's fluoride dropping into a frying pan. What's your brain on fluoride? So now let's get into the IAOMT's diagnosis, treatment, and maintenance and prevention concept here. So, the standard of care has really been risk assessments, education, prophies, keep brush clean, keep everything nice and clean, microscopic analysis, which we'll touch into, DNA analysis now, whoa, DNA, that's awesome. Okay, irrigation, root planing and scaling, even though root planing is not favorable anymore. Supplementation, of course, pocket reduction procedures, which everybody loves, right? Everybody loves getting perio surgery. Ooh, that hurts. Think about going back to dental school. The poor surgeons we had to do. I have to get out of dental school. I need 5 surgeries. They have no teeth left, by the way, I'm sure. Okay. Frequent recall appointments. And that's always been a bugaboo in our practice, is that, the concept of the 3 and 6 month recall. Where the hell did that come from? It actually started with Colgate seeing your dentist regularly. Every 3 or 6 months you used to see him. There's no scientific basis for that. None whatsoever. None whatsoever. So we customize our recalls to what patients need. Sometimes more, sometimes less. Laser therapy, that's awesome. Okay. And ozone oxygen therapy. That is very nice also. Okay. So diagnostic, the standard of care has always been taking a stick with measurements on it and stick it down around the gums. Okay, that's been around, forever and a day. Advanced concepts with Florida probe, but they said 3 or plus millimeters should be considered at risk, and of course, bigger than that is periodontal disease, meaning we're measuring the loss of the supporting structures around the teeth, and that gives you a sense of that. We're all familiar. We all love sticking sticks around dentition itself. Okay, so tissue tone. Well, maybe, depending on what the pharmaceuticals are being taken today. Periodontal tissue should be firm and pink. So I'm talking to the choir here, okay? If there are edema and erythema are common signs of periodontal disease, swelling, okay? And of course, it could be related to other disorders in the patient itself. And prescriptions and hormone treatments and all that affect the tissue. The tissue is what? Epithelial based. They're highly reactive to information. They're wonderful, but they do what they're told. Okay? And of course, a good medical and dental history, past and present itself. And of course, bleeding upon stimulation. That's my favorite, bleeding upon stimulation. That, of course, means that the epithelial lining is starting to break down. Okay? Those neutrophils are going to town, and that lovely epithelial lining is breaking down. We're seeing some bleeding and some congestion in the area. We're going to talk differently when we talk biologics. And of course, you stink. Okay, it's a fermentation. How many patients have you had come in are fermenting? You know what I mean? Only one. That's what you're wonderful out there. Okay, all right. They are fermenting. We've had patients come in, believe me, they are fermenting, all right? And that's an interesting process, fermentation, to say the least. And of course, we see abfractions and occlusal issues associated with that. But, malocclusions doesn't create the periodontal disease. It might just push it along a little bit because the way bone compensates for overstresses, but it isn't necessarily the root cause of it. And of course, we see different, we've talked about migration of the tissue down along the dentition, and we're seeing a multitude of different problems stay associated with that. With the pharmaceuticals I told you, to some of the chemotherapies or the radiation. Everybody's seeing radiation patients in the head and neck these days. Very, very complex to deal with, okay? Because of the damage to the tissue itself. And of course, you take into consideration, you can see the damage when they come in, we have an active or a passive situation going on at that particular point. And we can do microbiologic testing, which is always fun. One of the big things here with the Academy has always been the phase contrast microscope. And I consider this an nice assessment tool, and it's great for patient education. You can derive some basic information out of there. Any of these samples that we ever take, remember, talking about was interesting, going back in history. Okay, go back to, let's say, dental school years ago in the 70s or 60s. There were maybe 4 types of bacteria in the oral cavity. Then it became 40, 400, 4,000. Everyone's microflora is different. There's millions of different type of bugs. So when we sample things, we're just getting a little sliver of what we're actually growing and what's happening in your mouth or in the body itself. So let's take a brief tour of that. So the phase contrast microscope, it's a cost-effective, methodology. Once you invest in the scope itself, it's a great learning tool. It's chair-side. Usually your hygienists do that. And you're looking for different type of little bugs, which I'll show you itself, okay? We're looking for, fungus, treponemas with the spirochetes itself. All those things I kind of showed you before, which are a lot of activity in those particular areas. So you look for that and you show the patient. The advantages of it, it's chair-side. It takes about a minute or so just to harvest that. You're looking for white blood cells. You see all the spirochetes, a lot of craziness going on. And hopefully it's patient motivation. You put that up on the screen off the microscope, they see all kind of creepy things running around, and they hopefully freak out enough to keep things as clean as possible. And it's inexpensive once you make the investment of a few $1,000 into the microscope itself. Phase contrast microscopy itself. Okay? And here, you can take the risk assessment. You can see where, your typical biofilm is kind of quiescent. It's not moving, not doing much. Here, where you're seeing active pathology going on. A lot of activity. Spirochetes going berserker. You'll see red blood cells, all kinds of different amoebas crawling around. It's quite a treat. Not for the patient, of course. Okay, so it's really a motivational thing. It's an assessment, I call it. I like to call it an assessment. It's not a hardcore factual information. So, We're talking about biofilm, and you basically what you try to do is there's levels of maturity in the biofilm itself. From here, it's more oxygenated, and you try to get down to the bottom here where the most mature biofilm is, where the most activity is. And of course, you don't want to get in calculus or anything in there. And the risk factors you can look at: white blood cells, tryptonemia, which are spirochetes, candida, trichomonads, and amoeba. Those are kind of the key factors you would look for under the microscope itself. And some red blood cells, of course, with the damage to the tissue itself. So this is your typical, non-motile, if you want to call it healthy biofilm itself within the oral cavity itself. And then, of course, you start looking at these pleomorphic forms, the yeast forms. You have the mother forms, the hyphae itself. And they can be, mistaken for red blood cells themselves, these little bud factors. And they're tough as hell to get rid of in the typical sense. Okay, red blood cell there. And you can see here a hyphae under the microscope itself. And a live shot, ladies and gentlemen, of a hyphae. You can see how active it is. And nothing's happening yet, so we'll move on. It's just laying there. Okay? And this is, Griffin Cole's favorite bug. He told me to put that in there for him. And it's always kind of interesting having that swim around your head. Right, Griff? No comment. Okay. So it's a one-cell animal, and it's related to Trichomonas vaginalis, okay? But they're just an argument whether it's the same thing. Listen, you know what? If something's down there, something's up there. It's all over the place. All right, don't read into it, please. Anyhow, here's your Trichomonas oralis, okay? And it's quite a party. And think about that, and all you can see associated with, because this is coming from a more pathogenic, more mature biofilm, we can see all those spirochetes, trichomonas, and of course the cool little amoeba action over here where he just left somewhere. But you can see these guys running around there. It's always interesting. I got all this stuff from Oratech and Jim Landis, and it was awesome. He lent me this stuff, but it's always interesting. I don't know if he's going to be here this weekend, but he sets up his booth, and he has a microscope, and he takes samples. And it's always interesting when one of the dentists sit down, they do a sample, and they find the stuff on the dentist, okay? Because word goes out, the poor dentist sit there, and everybody's looking at him. Oh, amoeba. Okay. All right. That's always entertaining. And of course, here's your amoeba. And the problem with these guys is that, once again, when the immunologic response is over-responding, those epithelial cells start to become stripped apart. It allows these creepy crawlers to do what? Creep into the tissue. So how the hell do you treat that? That's a tough one, but we have tricks for that. So the amoebas, they're tough. You go in there and you try to poison them with some chemicals and stuff. They sense it because they can smell things, and these bugs run into the tissue, duck out, and when, coast is clear, they come back out. That's why it's so tough dealing with fungal forms. You're doing all kinds of weird chemicals to them, poisoning them, everything else. They all, I'm fungal free. Well, two weeks later, then here they come again. Here they come again. And, this is like, basic biology. Remember looking under the microscope at an amoeba for the first time? You thought it was like so awesome, okay? But they love eating white blood cells. Yum, it's like, barbecue for me, So, let's say, you're looking at the microscope and it doesn't look bad, but we're still battling with this. Okay, so what's the next step forward? Well, we can culture things and do, antibiotic-specific testing. That can be done, okay? But also, we can do more testing in the sense of doing almost like DNA testing. In this case, it's BANA testing. And this is kind of a slick little trick. Once again, it's an assessment tool because it's very limited on the number of pathogenic forms that it does test for. It's an enzyme system that you can bring into your office. And it's a chair-side microbiologic test, okay, for periodontal risk. It's very quick. It's cheap, $6 a test. And really, all it tests is for 3 specific type of pathogenic forms. So once again, it's an assessment form. Do we have a problem? Because if there's 3, there's a hell of a lot more of those different forms in there. So the advantages for this, okay, it's chair-side, 5 minutes results. Look for those weirdo type of pathogenic forms. Okay, it's as sensitive as DNA testing. Okay, they did a lot of comparative testing. This test has been researched more than any other test we know as far as the oral cavity is concerned. It's fully automatic and it's cheap. Once again, $6. But the advantage, once again, the disadvantage is what? It only tests three different type of components, and it's semi-quantitative, and it's colorimetric, and there's really no written report. And it costs you about $400 to get into the test itself. Okay, and they compared it to the DNA versus the sensitivity, and the comparisons were within 0.5%. So it's a very inexpensive, a nice testing kit, assessment kit to have in your office. Okay, and once again, what do? You always go for the more mature type of biofilm and harvest from there. Okay, and basically all you do is just smear it on the card, you fold it over, it's an enzyme test, and you can put it in the little incubator for a couple of minutes, and this is the card that you get out. Where it's negative, that stays clear, and you can see as it's more progressive, it's not even quantitative. It's really, qualitative in a sense that you see these positive, and then these are higher risk factors within the patient itself. So this is another assessment tool that you can look at the toxicity of what's within the pocket itself, minimum risk, elevated risk, and high risk itself. Okay, but it's been very factual. It's very consistent, because that's important to me. You ever take a test, you do a test, and then 5 minutes later you take the same test, totally different results. You're looking for consistency, reproducibility in any of these tests, and that's important, and this does do that. So this has been researched ad infinitum, okay? And it really correlates to even the DNA polymerase chain reaction. Once again, all they're testing is 5 different forms, DNA-wise. There's millions of different forms, and everyone's different. Well, that's why I call it an assessment tool, So the advantages, it's convenient, multiple species. It gives you an antibiotic guidelines. Does anybody do DNA testing in here at all? Has anybody done that? Well, I'll tell you my one bugaboo in a minute with this whole testing thing. Okay, it has a patient record form, really cool, big deal. Okay, it costs between $100, $129, and time, whatever. So those are the companies that do it. Microident and hand, which is on diagnostics, and my Periopath itself. Okay, so basically, one you kind of swish around, put your spit in a little bottle, ship it off. The other one, the Han test itself, is you take your little paper points, you put it around different 5 points around the tooth, take that sample, ship it off, and then you get a report on that. But the problem I've had with all these tests, I've done them all, is I keep on getting the same recommendations. The same thing. Amoxicillin, metronidazole, Arestin, chlorhexidine. Every single patient, I'm getting the same thing, same recommendation. What the hell's different? Nothing. So we have some other courses of action for that. Okay? And remember, once you go back into these pharmaceuticals, Arestin, old days. We used to pack tetracycline around pockets. There used to be a cord that was soaked in tetracycline. Arestin and all this other stuff. You think this stuff actually stays in that area? Once you're putting antibiotics in any form, okay, it goes everywhere, and you're disrupting your microflora itself. We had a discussion last week in our school weekend where one of the docs said that was a doxycycline. If you use it in a low dose, is an anti-inflammatory. I'm like, what the hell does that mean? An antibiotic is an antibiotic. So that was an interesting discussion. It may appear to have an anti-inflammatory effect because you're kicking down some bugs maybe, but an antibiotic is what? An antibiotic, an anti-life, okay? And sometimes, listen, that's why I love integration. Sometimes, guess what? You need an antibiotic, okay? But we've cut down dramatically the use of antibiotic. You get a cold, you need an antibiotic? No. What do you go to a physician? Get an antibiotic. It's nuts. That's why you have to do probiotics. There's a whole world out there. And of course, take in consideration the other things: systemic disease, chronic disease, cancers, Lyme, the physical, disabilities. Can they keep their mouth clean? Okay, their medical referrals, nutritional status, a good physical exam, all kinds of different type of testing can be done to find out what this progression is all about. And bad root canals. root canals are a real problem at times. Are they all bad? Probably not. But some of them, when they go bad, are nasty. This is, right here, a case I had where this is the root tip here. This gentleman's unborn twin came out. Okay, you can see the eyes and mouth and etc. I mean, man, you can't fix that. That's for sure. Okay? And this is the thing we're having with 3D cone beams. We're seeing things like huge holes in jaws. Oh, that's a healing scar. What the hell is that? This is, I don't know, what the hell grows in this thing? Who knows? Probably everything. But the biggest issue of root canals is fungal infections, but that's for another day. So you really grow, what you are, and what you eat. Hydration, what you eat, your habits, sleep, supplements, and living environment, your hygiene, and your whole body. Remember, you are an ecosystem. Okay, you're an ecosystem. Your ecosystem is balanced and functioning. You're happy and healthy. When it starts to slip down a slippery slope, where the environment changes, ecology changes, oxygen metabolism changes, you slip with it. Okay? So let's talk about the IAOMT's biocompatible periodontal treatment itself. So their recommendations, or our recommendations, right? Disinfect the mouth and eliminate the periodontopathic microorganisms. Okay? That's classic stuff. To remove as little healthy tissue as possible. In other words, leave a few papillas behind. I have a hard time doing that. Take a couple hunks out. What the hell? To remove the calculus, of course, of the deposits. Okay, that's always an irritant. We know that. And, once again, support the patient. Oral hygiene, nutrition, etc., smoking, booze. Not that there's anything wrong with that. But, we want to have good health and wellness. Okay? So, but the principal goal, in my mind, is really keeping that biofilm at an immature state. Is it that time? Okay, I'm almost to that break point. It's too much fun up here, actually. Okay. So periodontal therapy, comprehensive diagnosis, maybe microscopic analysis. Anybody do microscope here yet? Okay, awesome. You like it? I know Maddie loves it, man. The what? Now you're going back to it. I feel that. I feel it happening. And of course, treatment cycle depends on the patient itself. So, our concept, or my concept, and my dear partner in dentistry is clean the house, man. So on that note, we'll take a how many minute break? He left already. That's great. 10 minutes, Joe. We don't have a. What the hell you say? What's that? Oh, it's up to me. Take an hour break. I'll see you tonight. All right, let's take 5 minutes, and I know it's going to be 10. Yes, Bill. How are we doing on time? All right, 5 minutes then, please, okay? Because he told me to give you a break. I know I shouldn't, unless you don't want a break. We're spending more time bullshitting about the break. I'm sorry. Take a 5 minute break.